everybody. My name is Ian O'Brien. I'm the Executive Director of PASS, which is an acronym for Performer Availability Screening Services, which is actually a vestige of our program. We do much more than performers anymore, but I've put together a little bit of a slide deck to explain who we are as an organization, who I am, what we do, and kind of our vision for health and safety in the adult industry. So who is PASS? What are we? We're a health and safety nonprofit organization for the adult industry. We're most well known for our guidelines on testing protocol, work clearance for performers on studio sets, as well as our testing database, but we do much more than that, anything within the purview of health and safety of the adult industry. We've got a pretty long history. So testing has been around in the adult industry for a long time. But in 1998, performer Sharon Mitchell kind of formalized and centralized testing protocols for the industry. Largely as a response to the AIDS epidemic. The idea, like, testing had been around, but having a central place to kind of govern what was getting tested for, why it was getting tested for, and to share results was essential for managing the process. And AIM, which is Adult Industry Medical Healthcare Foundation, I believe, was a set of industry-run clinics that partnered with testing facilities throughout the Los Angeles area. In 2011, they ran into a bunch of licensing challenges and had a major data breach, and so the program fell apart. The Free Speech Coalition, which is FSC, which is a trade association for the adult industry, adopted PASS as a program at that time. It was originally called like APHSS or something like that, before they came up with something more pithy with PASS. Because we needed centralized governance and a database for testing, both for regulatory purposes and also keep the industry safe. As of last year, we actually split off of FSC to become our own organization. So we're our own 501c4 organization, but nonprofit, with our own board. So we do share governance with the Free Speech Coalition. It's complicated, but one of their board members is my board member, vice versa. We work really closely together still, but the idea in splitting off as an organization was so that we can more specifically focus our work around health and safety work for workers, and kind of expand the mission beyond just the testing database. I'll talk a little bit more about that in a bit. But the industry has radically changed in the past 10 years since PASS was an idea. And so with this past year being off on our own, it's really been a process of reimagining who we are and what health and safety might look like for the industry. So I'm excited to talk to you all about that today. Just a couple stats on our programs. In 2019, which is the last fully reliable data set I have, because in 2020 we had COVID, and so there were several months where tests weren't coming in, and then we had a bunch of changeover in lab partners. But in 2019, we had over 20,000 test panels come through our database. That means people got tested 20,000 times, which is huge. And we also know that, like, not everybody is necessarily being entered into our database. So you can imagine this is if people are spending $150, $160+ on tests. That's prior to COVID. We've got $3.5 to $4 million going into testing annually every year on the low level, just through PASS. So there's a lot of money going into testing. On our end, we also manage a program called the Performer Subsidy Fund, which I'll talk a little bit more about later. But since its inception, we've provided over $1 million in subsidy funds to the industry. And also our major success is that since the inception of PASS, there's been no HIV transmission on a PASS regulated set. So a little bit about where we are. So before I go into detail about what we do as an organization, I want to talk a little bit about the difference between public health and individual health. Public health, you might have also heard terms population health, community health, though they're not necessarily interchangeable, but for our purposes, they're similar, is the looking at population level approaches to health. So not just making risk assessments based on somebody's individual needs, but rather how can we most effectively use the resources at our disposal to protect the most people. And how do we weigh the kind of ethical concerns, access, resourcing concerns, and like the difference in risk tolerance in a group of people versus like specific individual needs, and how do we impose the least on individuals' autonomy. This is counter to individual or clinical health, which is what happens when you go see a doctor, in which you're allowed to get a level of personalized care targeted to your specific needs, at least in theory. Like you're able to negotiate with your clinician around what health options you might need. They are able to take a more detailed understanding of your medical history and provide you with specific solutions. And the training for these two groups is very different. Like clinicians go to clinical school, either medical school, nursing school, some other kind of clinical route in order to provide care. And they're licensed under this ability to provide specific care to you. And there's a level of autonomy that they operate under there, as well as practicing medicine. With a license, you're allowed to like develop individualized solutions and provide, at least in theory, I'm caveating this because of the complications of insurance and social systems, but in theory, individual clinicians are able to provide you with a personalized level of care based on what you need, and they have flexibility to operate within that. Public health folks operate on regulatory guidelines, statistics, algorithmic measures. So they're not creating individual care for folks, or we're not, but rather looking at populations as a whole and seeing kind of how we can create systems in order to keep the most people safe at once. How this plays out in terms of our own care, for an example, is with herpes. On an individual level, I'm just using herpes as an example, but on an individual level, you might be able to talk to your clinician about your specific herpes risk. If it's something you're very concerned about, you can get screened for it, and you may or may not get a test result. On a population level, and the reason that we don't test for it as part of our protocol is because, one, the herpes test is unreliable, meaning, unreliable, no, let me be fair. It's not as reliable as other tests, meaning that there's a high likelihood for a false positive or a false negative, meaning that the result could be wrong, particularly if you haven't experienced symptoms. The prevalence of herpes is so high that we be screening a lot of folks out that may not have ever had symptoms or be able to transmit the virus or have those false positives. And public health had actually made a decision many years ago to stop having regular screening of herpes because of the level of false positives was causing a lot of folks a lot of psychological harm. They get a positive herpes test result, not know how to cope with the stigma or diagnosis of that, be very anxious or celibate for years until they found out later that they didn't actually have herpes. And so like the regular screening for it was actually not affecting public health in a positive way. Now, on an individual level, where you're able to have a conversation with your clinician and talk about what that means and evaluate your own risk and talk about symptoms, your decision to get a herpes test might be something that fits your unique need. So that's just an example of the difference between the two. PASS and myself will operate in the public health sphere. My background is in sexual health and reproductive rights. I worked at a number of mostly LGBT nonprofits doing abortion organizing, queer and trans rights organizing, both domestically and internationally, working on refugee issues. And so this work kind of naturally fit into my field. Where I don't operate, though, is on this individual health level. I can't, you send me a picture of a rash, I'm not going to be able to determine where it came from. I can identify places for you to go and get help, but I couldn't provide that directly myself. All right. So we've got a variety of programs. What I mentioned, what we're probably best known for is our testing protocol and our database. And those really fit within the regulatory affairs, health and safety, and work clearance area. So in terms of regulatory affairs, a lot of the work that I do is talking with the regulatory bodies on a state, local, and federal level. Cal OSHA being a group that I interface with regularly, or at least used to, in order to set appropriate guidance for the industry and also interpret that guidance for the industry in terms of health and safety guidelines. So I'll go over our protocol, testing protocol in a minute. But STIs, COVID, other emergent diseases, we provide insight to the industry in collaboration with legal experts, medical experts, and public health experts in translating these kind of regulatory guidelines in the best way to keep people compliant on set and promote health as best we can. And then work clearance, we operate a database so that folks know where they, when folks have been cleared for work and that they can reliably check it, and it's not a complicated procedure to figure out. And that also the privacy and record keeping are major regulatory components and things that people have to look out for. And so our operation of the database is useful for that. Infection controls, we will on occasion, if there's a significant threat to the industry or potential threat to the industry in terms of infectious disease, call a production hold, meaning we shut down the industry or production until we can identify and isolate any potential exposures to the industry. And so us operating the database allows us to identify and expedite our kind of investigatory process there. The Performer Subsidy Fund is a program we operate. We get donations from production companies in the industry monthly to go to a fund in which we redistribute to folks who get tested. So as I mentioned, over the past, just since its inception, we've given away about $1 million. But how the program works, and anybody can sign up for it if you're getting tested at a past testing partner. But usually amounts to about $20 a test, give or take. But what we do is we take the number of tests within a given time period and divide that against the amount of money we have, and then redistribute that to folks. We've started issuing checks about quarterly now, I believe. But if you're getting tested with PASS or any of our testing partners, there's a good way to save some money or get some money back. This past year, we've also really started to expand our health education and resources for the industry. There's a lot of sexual health information out there. There's a lot of really wonderful folks doing a lot of great work educating people. But there's not a lot on the intersections of sexual health and occupational health for a variety of reasons. And so we wanted to be able to start to build out information for the industry of like why we test for what we test for, and other strategies for folks to protect their own health. And then we also work on a number of community health initiatives. I actually think the majority of my job is responding to whatever fire is going on in terms of health in the industry. As we are all intimately aware, the past nearly 3 years now have been dominated by COVID as a global pandemic, but also dealing with a number of emergent diseases that might not be a fit for our standard testing panel, like Microplasma Genitalium, which we have a pilot program with for, and monkeypox, which is a growing concern globally. And so identifying how to intervene on those pieces, what kind of strategies we can apply to the industry is a significant amount of our work. So I'm going to check the chat real fast just to make sure I'm not. Okay, we're good. Our testing protocol. So this is the bulk of our work, again, what we're most known for, but PASS provides guidance for a standard testing protocol to clear performers to work on studio sets. We test for 7 STIs using a panel of 9 different tests that clears folks for 14 days from the date of the blood draw. So if you get your blood drawn on a Monday, or the complete panel on a Monday, and you get your results back on Wednesday, you're cleared for 14 days from that Monday. Our panel is unique to our industry. So as you can see, there's 2 different sets of tests for HIV. The first one, that PCR test, is why we have the 14-day timeline associated with it. Most clinics that you go to get an STI test will not offer what is called a PCR test. It's funny, when I first started talking about PCR tests, folks were not as familiar with what that meant, but COVID has made us intimately aware of PCR tests and antigen tests. But essentially, the PCR test is looks for the virus itself directly in the blood, and has an earlier detection window than an antibody or antigen test. If you go to a testing clinic and get an HIV test, they are likely going to give you this 4th generation antibody antigen test or something equivalent. The reason is that most people get tested at most every 6 months, which is ideal. 3 months if you're on PrEP. I would say most people don't get tested, or if they do, it's annually. And with that, like, lack of frequency of testing, this antibody antigen test is able to catch HIV infections in a pretty large time frame, and it's much more cost effective than using this PCR test. For the adult industry, we're testing much more frequently and want a much greater assurance regarding the potential transmission on set. So we use this PCR test with an earlier detection window. It is more expensive, and it's the biggest reason that it is hard to bring labs into the PASS network. Even the large corporations, if you've heard of LabCorp or Quest, which are major lab providers, in North America, while they do this PCR testing, they're usually only running their machines on it about once a week. So if we were to use them, folks could get tested and then wouldn't get their test results back for 7 days or longer. And if you're operating on a 14-day time period, you've lost so much of that to just waiting. So that's one of the biggest reasons why it's difficult to find lab partners. The 14-day window is also tied specifically to this test. The theory of our testing protocol here is if you contract HIV, it's around 10 to 14 days before you become potentially infectious. With our PCR test, it can detect an infection as early as 3 days, but reliably at 12 to 14. So we have it set at the 14 days. And the thinking is that if somebody were to test negative for the PCR test, then get an infection, an HIV infection during that time period, their testing clearance would expire prior to them becoming infectious, meaning that even if we weren't catching an HIV infection within that time period, folks would still be protected. And the rest, there's a variety of reasons for us doing. One of the, I won't get into the extreme detail on each one, but one of the things that I really want to do with PASS in the coming year is start to figure out where we can adapt this testing protocol. It made a lot of sense 10 years ago, but currently, like this hepatitis B test that we do every time, most folks are vaccinated against hepatitis B. It is very unlikely that we need to be testing for that. And if we had a managed care system, we'd be able to just check vaccination status and move against it. I also want to make sure, right now we're not doing swabbing as part of the standard protocol for your throat or your butt. Right now it's just a urine test. And we could be missing potential infections that way. But taking a public health approach, part of the challenge is that if we implement swabbing right now, the last thing I was quoted on was about $60 per site. And I can't, if I increase the testing panel to be almost $300 at that point per person, we lose people within our ecosystem. So like, while the individual test might be more robust and safer, having people not use the system due to lack of access or resourcing would ultimately make it more dangerous for everybody. So that's one of the things that we weigh. So, our clearance database. I'll show you a little bit about our database in a second, but it is incredibly lightweight. And it was designed that way on purpose, given the fall of AIM and the reimagining of the program. This clearance database was designed to have as little information in it as possible. So we partner with a variety of lab partners who test people based on our protocol and send those results to our system. Or I shouldn't say they don't send the results, they send work clearance based on that protocol to our system. So no results are received by PASS at any time. We only receive a binary, has this been personally cleared to work, yes or no. If somebody hasn't been cleared to work, we don't know why that might be. It could be a positive test result. It could be an incomplete test. It could be a false positive. And we would never know. And it was designed that way to keep people's information as private as possible. And also in the off chance that somebody is able to hack the database, that they're not getting any meaningful information. So if all of the information in the PASS database was leaked to the world, all they would see was a list of names of whether or not they were able to work in a certain period of time. For that same reason, we also don't couple performer name or stage name with a legal name in the database, because we don't want people to be able to, if the database is hacked, be able to discern who's who. Another reason that we manage this database is we can centralize results. So if folks have gotten tested at Talent Testing or TBD Health, right now you have to check a number of different places in order to see who's cleared for work. And us being able to have a single location where all the labs feed into means producers can check one place and know that those results are valid. PDF and paper results are editable, aren't necessarily reliable. I actually have a message in my inbox right now around potential forged results in the industry. So having a kind of database where folks can check results and verify that they're real is important. The medical record keeping is also a big deal. So I don't remember if it's a California or federal law. I think it might be federal, but medical records requested by employers are required to be kept for 30 years after they've been requested. And so PASS, being able to operate just a clearance database, allows folks to get past that kind of record keeping component. So they're not keeping paper test results in a file for 30 years past their shoot, but rather they can just check a database and make a note they've checked the past database. And as I mentioned, designed to have as little information as possible. Privacy is paramount. So right now, also, we want to make sure that people are only in PASS if they very explicitly want to be. So we have a dual consent process. One, if you're working at or testing at a PASS affiliated lab, they'll provide a consent of whether or not you want to send your results to PASS, and so you can agree to that. But then, if you don't have a confirmed account with us, an email will be automatically generated where you have to agree to post your results on PASS yourself. So there's two steps. One being I agree to have my results sent to PASS, and two, from PASS, I agree to have my results displayed on the PASS website. So that way we hope that folks are only participating in the program if they very explicitly want to be. Then I'll just show some quick data screenshots of the database. The website is app.passcertified.org, by the way. So if you went to go look up somebody in the PASS database, I'm using PolyPass here as a fake person we use for demonstrations. You can see their clearance information. You search for PolyPass. You can also search by Pass ID. You can see Pass panel clear, meaning like, has that STI panel been cleared? The green check means yes. The 14-day expiry is when the test would expire. So this person got tested on likely the 15th. We also implemented a COVID-19 vaccination verification system. So like you can submit your information to PASS and we'll verify that you've been vaccinated on the website. We, on the onset of COVID, we implemented this COVID test date piece. So you can see the number of days since they have last been tested for COVID. The test date would appear if it was in the last 3 days, I believe. But the idea for us there was that we knew that we were going to have a dynamic process in terms of how frequently people needed to make COVID testing. So we didn't want to have it be a simple, clear checkmark system like it was with the PASS panel. So folks are able to evaluate, do I need someone to be COVID tested within the last 1 day, the last 2 days, the last week? And that was kind of our dynamic system. That is the one place where we kind of receive specific results. Like we don't receive anything about your specific test results. But except for if you've been cleared for COVID, we did receive guidance from, I can't remember what government department, which made it more relaxed on privacy regulations regarding COVID information. But that's the one place where we would get something specific. And then here's an example of if somebody's not cleared for work. There's just a red X. And again, you couldn't tell why this person wasn't clear. You just know they're not cleared right now. Maybe they didn't get tested at all. You don't know. It's great. But like having that kind of very simple binary, we know whether or not somebody has adhered to a panel or not, and there's no questions asked, there's no complicated matters, is really the core of this program. And then testing partners. So one of the, I had mentioned them before, but PASS doesn't do any testing directly. We partner with testing partners to provide the test panel to the industry. Our current testing providers are TTS, TBD Health, or TTS Talent Testing Services, which is the largest one, TBD Health in Vegas, and then Nobility Health, who does COVID testing in Los Angeles. So we'll be very soon adding a partner to Miami. But they all agree to offer the standard PASS testing protocol to the industry and report it to our database. They also agree to follow our policies and procedures in doing so. So when I'm looking for a lab partner, I'm looking for somebody that's able to provide the standard testing protocol, turn it around quick enough so that it's able for the industry to use, which is usually the biggest challenge in finding somebody, is finding a lab that can turn around a HIV PCR test result within 1 to 2 days. And then I also need some kind of relationship with them to assist in production holds. Due to privacy regulations, when somebody tests positive for HIV in the industry, I don't know who that person is unless they choose to disclose. So having a working relationship with the labs and testing partners within our network to be able to help reach out to that person, do some of the contact tracing and discussion with them, and seeing if there's any risk to the industry is really important. Our testing partners also need to be CLIA certified. So I do not remember what the acronym, I want to say it's like clinical laboratory something. It's clinical lab licensing in the United States. But we require all of our lab partners to have that licensure. And then we also require that they have some sort of privacy policy. HIPAA is something that, which is a Health Information Portability Accountability Act, something like that. Health insurance portability. You don't care about me explaining acronyms, but it gets misapplied frequently in that it really only affects certain classes of folks receiving certain kinds of funding or tied to health insurance. So not every healthcare provider actually needs to abide by the rules of HIPAA. And because the testing partners that we work with typically aren't receiving federal funding or operating as a standard care provider, they might not have HIPAA regulations apply to them. So it's important to me and to PASS as an organization to make sure that anybody that we're working with has a robust privacy policy to make sure that any information they receive is protected. Oh, I got a question. Greg, I just saw your question. Do I click answer live? How do I do this? Anyway, Greg is asking, what is a reasonable for two individuals looking to create adult content? So like not a porn studio set. So that's a really good question. So if we look back at our protocol here, this was created for like our studio work and kind of standard over a large population. For two folks, this will solve a lot of problems. So if you're, if this is, you're just looking for something to utilize that is going to be the most risk-averse option that you have, this is a fantastic one. Now, if you're willing to negotiate risk differently, or have different levels of resources, or like understand each other's sexual practices, you might adapt something. So getting screened for just the antibody antigen test and not the PCR test every 3 months is a fantastic option. If you know folks have been vaccinated for hepatitis B, that might not be needed. This syphilis test, so right now there's two on here. There's RPR and there's treponema antibody test, otherwise known as like a Pcr test. We conduct both of them because one has an earlier detection period, but if you've ever been diagnosed with syphilis before, you will always come back positive on one of the tests. And so we need the other to confirm that there isn't an active infection. And so we run them simultaneously on a population level to make to expedite things. For an individual who syphilis history, you might only need to run the one where they've never had syphilis, or the one where they have had syphilis previously. So it really, I don't think there is necessarily a static answer for that. We're hoping to put guidance out for individual content creators, folks that aren't doing studio porn, to kind of be able to adapt to. I think at-home testing is a fantastic option that I've been really looking into and exploring for us. But I wouldn't say at this time there's a panel that we could recommend widespread without knowing whatever your individual needs or circumstances are. But if you need something that is going to give you the greatest risk reduction, this panel will be it. I hope that answered the question. All right. So the next part, I'm going to talk about kind of emergent diseases and what we're doing for stuff coming up. But before I move on from like our testing protocol and kind of our lab partners, I just wanted to check to see if anybody had any further questions. I'll also give some time at the end. Perfect. So emergent diseases, this is the kind of community health initiatives piece. So in the past 3 years, we've had a number of emergent threats to the industry and world that can't be resolved by our typical testing protocol. And so we've kind of had to adapt with different responses to continue to adapt to kind of address each of them. COVID-19 being the most notable, but also Microplasma Genitalium and monkeypox. I'm going to talk about them really quickly. So COVID-19, I'm sure everyone is very familiar at this point, but it's a novel viral infection that we discovered the end of 2019, highly infectious, prone to mutation, meaning that it's difficult to develop a individual vaccine or cure for that, like our catch-all. Vaccination is fantastic and highly protective. But as we've noted with mutations, particularly the most recent ones, that it doesn't necessarily prevent against transmission. Really strong for preventing serious illness, but this mutation piece has really made it so it can get past your initial immune system response. And it's also a global community challenge. So most, not that STIs are not also a global issue, but on a community level, you can develop like very specific interventions. And it's easier to track how they might be spread. We can trace that. It's much easier to count the number of people that you've had sex with than it is to know every single person you passed on a bus, right? So COVID, it became really challenging to address spread. Us, along with the rest of the world, when this was first happening, really needed to kind of invent things with a lack of information. We knew we're also in a very high risk industry in terms of closeness. We didn't have the luxury of kind of creating barriers between people performing. Though, if anyone remembers, really early on, I think the New York Public Health Department put out guidance saying that people should start using glory holes more, which I thought was just excellent public health. But for us, we needed, like, what can we utilize to really mitigate infection when close contact is necessary. Fortunately, we already had testing in place. So setting up facilities to be able to just add on a COVID test was pretty easy. Early in the pandemic, I got a lot of calls from Hollywood producers looking to replicate our system. I think they were looking for something a lot more robust than what we've got, pretty scrappy. But I think what we really had going for us as an industry was that we had some kind of cultural mechanism in place in which we understood what testing is, how to interpret those results, where to go get it. And so it became a pretty effective strategy for us. We also did a lot of vaccination promotion. Vaccination remains a great tool for reducing the spread, but most importantly, reducing the serious risk of illness for the virus. Before we knew that vaccination was not perfect at preventing transmission, we had implemented that vaccination verification system so that folks who were vaccinated could get tested less frequently. We changed that as the science grew. That was also that flexibility in protocol, knowing that there was going to be a variety of risk on sets and what people needed to adapt to. And also like ever-changing scientific landscape as we learned more about the virus, we wanted to be able to build a protocol that people could adapt. So as you saw in the testing database, instead of making a very binary, this person is cleared for COVID or not, we built in days since their last COVID test. And that was just one of the mechanisms we have for that. And then this is like 50 minutes, right? Yes, an hour. I'm trying to see if I need more time for questions. I don't know, let's go. So Microplasma Genitalium is a small bacterial infection we've known for a while, but has been getting increasing interest from the public health community because we think it might be much more prolific than we had originally understood it to be. Recent estimates make it as common as, if not, or more common than gonorrhea. And it is a very small bacteria that lives in your reproductive tract or your butt, and provides symptoms similar to chlamydia or gonorrhea. It's so small that it is really hard to test for. So until 2020, there was no, I believe it was 2020, it's the past couple of years, there was no actual commercially available test for it. So if you want to get tested for Microplasma Genitalium, you'd have to go to a public health lab or have it be sent to like an off-brand test to kind of check to see if this was what you might be infected with. It's also a diagnosis that you get by ruling out chlamydia or gonorrhea. So frequently what will happen is somebody will go in for symptoms of chlamydia or gonorrhea, painful urination, potential discharge, itching in the genital or rectal regions, get treatment, standard treatment, it won't resolve, and then the clinician will test for it. That's the current standard guidance. So it's not typically screened for, which is why we don't have a lot of information on its prevalence. Over the past couple of years, I've been receiving increasing anecdotal reports of people with Microplasma Genitalium in the industry, and wanting some kind of solution for it. It would go against CDC guidance for us to offer this test as screening. Right now, as I mentioned, you only test for it if somebody is symptomatic and other things have been ruled out. It would be not clinical guidance to have it be flatly screened for. So we needed to figure out a solution for it. Fortunately, we had Spank Chain approached us at the beginning of this year to want to sponsor a program to screen folks for it in the industry, or develop some kind of pilot program. Initially, we wanted to do a full research project because there's no information on this, but instead, we decided we wanted to expedite it and just get people into care as fast as possible. So we partnered with TBD Health in Vegas to be able to send folks test kits for MGen for free in both Vegas, Nevada, or Florida, where they're licensed, to be able to screen. And if they do test positive, their treatment would also be covered. So that's all no cost. That was important because we don't know if treating asymptomatic MGen is a good or bad thing, and we didn't want to put people, have people cost people money if it wasn't something that needed to be treated. So we needed an innovative solution here. And then we're just kind of educating folks about it. MGen or mycoplasma is one STI that no one's ever heard of. So I think just getting the word out there and kind of figuring out, learning more about it, getting more people screened is our first step to kind of figuring out what we can do long term. That program is still running, so if anybody is just in Nevada or Florida, you can sign up for this program at no cost. If you're in Vegas, you can also go in and get tested at TBD Health at no cost. And the last one, really quickly, is monkeypox. So this appeared on the scene about a month ago, maybe a little over a month ago, like the end of May. When are we? About 2 months. It's a rare viral infection, was endemic to Central Africa. This really, there are 2 strains, and fortunately the strain that is making its way around the world right now is not lethal. But this really freaked me out when it was first reported, because all of the headlines were like 10% mortality rate, which is enormous and terrifying. And so there was a good week where I was deeply panicked that 10% of the industry was going to have to deal with a terrible virus. But monkeypox is similar to smallpox, less severe, and other pox viruses where you get a rash and lesions on your skin that are incredibly painful and can be passed on through touch, large respiratory droplets, meaning if you like spit or leak on somebody, close contact. It has a long incubation period. Fortunately, during that period of time, someone's not infectious. So if you've been infected by monkeypox, there's 1 to 2 weeks before symptoms will appear. The incubation period is the time before symptoms appear. And you are not infectious during that time. That said, you can get, once symptoms start appearing, general malaise, headache, fever, and before lesions, you might be infectious. But when you have lesions, they're definitely infectious. And you will be infectious until the lesions or rash scabs over and falls off and new skin regrows. There are vaccines available for monkeypox. One of my biggest fights right now is trying to get those vaccines available for the industry because they are right now being prioritized for only very specific folks. Until yesterday, you either had to be exposed directly to somebody with monkeypox or be a gay man or trans woman who has been diagnosed with syphilis or rectal gonorrhea within the last 3 months at a community clinic, which personally I think is super obnoxious criteria and not a great public health tool, but I'm not at the Department of Public Health. So right now, what we're doing, testing is not an effective strategy for monkeypox because lesions need to be present for it to be tested for. So we can't screen for it like another STI. So really what we have is education. If folks see a suspicious rash or pimple or something that they do not know what it is, go get it checked out, particularly if you're at risk. That's number one spread. Keeping things as clean as possible. So disinfecting sets before you use them, also a great strategy to prevent spread. But really where I think our most important tool and way to intervene is by building partnerships with local departments of public health to get vaccine supply. I'm hoping within the next week to at least have a number of vaccines available in Los Angeles, and but we'll see how that goes. But I think here our strategy is really reliant on working with other public health organizations and global health communities to kind of affect anything on set. So that is a big overview of what we do, kind of the breadth of it. I know I got into the deep detail some places, but thank you so much for your time. And if you have any questions at all, please feel free to reach out to me via social media or email anytime. And thank you so much, Pineapple Support, for having me.